Thank you, Professor Hung. It's been a really great time in Seoul that I've spent, and I've been really inspired by all the amazing work done at Samsung Hospital and Asan Hospital, so thank you so much for your invitation. So I'd like to talk about how we can implement mobilization at the early timing. These are my conflicts of interest. So first, I'd like to touch on what I mean by early. And we have learned a lot in terms of what the efficacy of mobilization will be in the framing of how soon should we get our patients up and moving. Then we'll talk a little bit about the barriers to timely mobilization and how to overcome those barriers so that we can effectively deliver this intervention at the right time. So if we look at all the clinical trials of early mobilization, there's a lot of heterogeneity on when they start therapy. Do they either tether the timing of therapy from ICU admission, which makes sense for patients who are not mechanically ventilated to sort of set the clock that let's time the mobility session to when they enter the ICU. But the majority of clinical trials actually involved patients on ventilators, and so perhaps we should time the therapy based on the time that they were on invasive mechanical ventilation. Unfortunately, some trials actually report the timing of their therapy based on when they were randomized, which as clinicians, we don't have a randomization time for when patients come into our ICU, so it's hard to then interpret those findings into the bedside clinical care. And interestingly, for an intervention that is named as early, some trials actually provide no data on what the timing of the intervention actually was. So as clinicians, we're sort of left a little confused as to what is the right time for mobilization. The other aspect is when should I start the clock and when should I end it? So what is mobility? What is actually the minimum dose of mobilization that would be effective for my patient? In some trials, they mentioned that the time to mobilization was in-bed passive range of motion. And I'd argue that that intervention was actually the intervention delivered to usual care patients that had no clinical benefit. So in-bed passive range of motion may not have the potency that we expect for mobility. Others loosely defined the intervention as physical therapy, but when you look at how they define it, it could range between in-bed mobility, transfer training, balance training, resistive exercises. Some clinical trials included physio and occupational therapy, so it's really hard to understand what that intervention is. And then finally, what might be a little bit more clear is to say, what did they do in the session? What was the milestone that they achieved to determine what is the minimum dose necessary to see the effects of mobilization? So there are standardized tools to measure what the mobility scale is, and so this is one of them, the International Mobilization Scale. It's an 11-point scale where at a scale of 0 means no activity, and can go all the way up to 10, which means the patient's walking independently. And as you can see, as they describe the different definitions of this scale, there's an inflection point at which patients go from passive activity to active activity, and specifically when they go from in bed to out of bed, or sitting at the edge of the bed, activating their truncal muscles. And I would argue that that's the minimum dose for mobilization, the first out of bed activity. And so when we want to standardize the timing of mobilization, looking at the lens of those who are at highest risk of immobility, those who are intubated, perhaps we should start the clock at the time that they're intubated, and then look to the first minimum dose of activity, which would be first out-of-bed activity, sitting at the edge of the bed. So now the question becomes, how long should that time be? What is the minimum amount of time that we can achieve to actually see the benefits for patients? So what I like to do when I think about that question is, what am I trying to achieve with mobility? I'm trying to prevent weakness. I'm probably trying to preserve the mind. And I want to be better than the negative clinical trials in terms of their timing. So it might be informed by what is the pace of muscle loss in critically ill patients? How soon will they develop the risk for cognitive impairment? And finally, what was the timing of trials that achieved a clinical benefit of mobility versus the trials that did not? And so just take a reference into what we're dealing with. If we look at patients who actually are healthy at baseline and are confined to bed rest, and we look at the pace at which they have muscle loss, it's important to recognize that they actually have a lot of strength loss that is underestimated by the degree of atrophy. So if you look at long-term bed rest in healthy adults, at about 4 months of bed rest, they'll lose about almost 20% of their muscle mass. Now, if you contrast that pace of muscle loss to a critically ill patient, critically ill patients, regardless of which muscle you're looking at, upper extremity or lower extremity, they lose about 2% of their muscle mass a day. So what a healthy adult will lose in 4 months, a critically ill patient will lose in 10 days. And so that's the race that I'm kind of running against, avoiding this extreme muscle loss where patients will have significant atrophy that underestimates the degree that they have developed the weakness. The other clinical outcome I'm trying to motivate myself by is the duration of their delirium. So in a large observational study, patients who had respiratory failure and shock were followed for a year and had in-depth cognitive testing. And what they found was that the duration of delirium was associated with the risk of long-term cognitive impairment. And it's cognitive impairment that is on the spectrum of total brain injury or Alzheimer's dementia, all in patients who had no prior cognitive impairment before their critical illness. And as you can see here on this graph details the scores on the cognitive testing, indicating lower scores means worse cognition, as a function of how long you were delirious. And you can see that the pace of this loss of cognition actually kind of slows down after the delirium has persisted for 5 days. And so my goal is, if I'm going to try to avoid that delirium, is to try to induce activity within those 5 days to prevent that long-term cognitive impairment from occurring. And then finally, we can be informed by other trials and understand what was the timing of those interventions, understanding that sometimes there's a little bit of lack of clarity for that. But if we look at large randomized clinical trials in prominent journals, you'll see that those studies that were unable to demonstrate a benefit of mobility, on average, started their first session between 5 to 8 days after intubation. And so this is after these patients had 2% muscle loss per day, so at least 10% muscle loss by the time they got their first session. If you contrast that to the 3 other trials that showed clinical benefit, the time to first out-of-bed activity, the time to sitting, ranged between 26 hours and 3 days. And so if we really want to see the clinical benefits of mobilization, the time is money, the time is muscle, the time is brain. And importantly, in our recent trial, where we on average had patients getting out of bed at 26 hours, our control group that had no clinical benefit from mobilization had an out-of-bed activity at 4.5 days. And so that tells me that 4.5 days is still too long, and that perhaps we need to move the timing of our therapy even sooner. So when I'm talking about early mobilization, when I say early, I mean achieving out-of-bed activity within at least 3 days of mechanical ventilation. And this is informed by preventing that 10% muscle loss that we'll expect at 5 days, also reducing the risk of and duration of delirium by half, and also informed by the timing that was achieved in positive clinical trials, but also the control arm of these positive clinical trials. So one could say, well, that's great. I want to mobilize my patient as soon as possible, but look at all these reasons that can be challenging to do so. So, there's concerns about how do you develop this process? How do you coordinate that care? The first 72 hours of ICU admission are the busiest. You're doing scans, you're doing procedures, you're resuscitating the patient. How am I going to find that time to mobilize? In addition, the ICU culture has to be built where the priority is also mobilization in addition to resuscitation. And there can be structural factors where you need to have adequate staff and equipment and protocols to help guide this kind of care. But when you survey all the different reasons for barriers, interestingly, the majority of reasons are related to the patient. And 3/4 of the time, if it's a patient-related factor, the number one complaint is that the patient is too unstable to receive out-of-bed activity. So let's ask that question, is that true? Because the reality is, in these trials, the timing of therapy was done within 3 days, and yet in clinical practice, these patients are considered too unstable. So could it be that these trials cherry-picked patients that were stable and, got the intervention? Or could it be that we might not be recognizing the windows of opportunity to mobilize these patients in that first 72-hour period? So when you look at the criteria to start mobilization as defined in these clinical trials, the trials done out of University of Chicago use primarily vital sign stability. So the patient had to have adequate saturation, adequate blood pressure, and heart rate in order to engage in out-of-bed activity, and there was no limitation on how much organ support that the patient had to have in order to initiate their first session. If you contrast that to the team study, they included vital sign stability, but they also put guardrails on how much organ support the patient could be on. So they said that patients could get mobilized if the ventilator was set to 16 of PEEP or less. You could also get mobilized if your norepinephrine dosing was 0.2 or less. And finally, they also included biochemical testing with a lactate. So if the lactate was 4 or less, the patient could initiate therapy. In 2014, so now over 10 years ago, there was a consensus guideline that posited potential criteria to say patients can be mobilized. And they used a more graded approach, a stoplight sort of metaphor, where if patients met any criteria in the red category, so they had hypoxia or they had hypertension or hypotension to a certain degree, then regardless, the patient was too unstable to mobilize. However, if the patient met all of the green criteria, this patient was quite safe, and so you should feel emboldened to go ahead and initiate therapy. If any of the yellow criteria were met, then it was a sort of a risk-benefit analysis to determine what's the benefit for this patient to preserve their functional independence. Perhaps I will proceed with caution, but still have some help in order to mobilize these patients. So what we did is that we took all ICU admissions at 8 health systems in the United States, and we looked at the vital signs of these patients in the first 3 days of mechanical ventilation to see were they meeting criteria based on the Chicago trials, based on the team study, or based on consensus guidelines to determine are there windows of opportunity that we're missing in terms of eligibility for mobilization. So this is part of the CLIF consortium that takes electronic healthcare data across different health systems, and the ones that participated in this analysis are listed in red here. So we looked at patients between 2020 and 2022, adults on invasive mechanical ventilation for at least 4 hours. And we primarily looked at the time that they were eligible when a physiotherapist would be working, so 8 o'clock in the morning to 5 o'clock at night. And we looked in the first 72 hours of intubation. Patients could not be on paralysis to be eligible. And then we looked at whether they met criteria for the Chicago trials, the team study, or the consensus guidelines. So this included about 84,000 patients. The median age was 63 years of age, with about 40% were female. About 2/3 were white or Caucasian, and the rest were a variety of different races. The mortality was about 26%, with a median SOFA score of 7, indicating an average severity of illness for an ICU. About 2/3 of the patients were on vasoactive agents, and we then applied this analysis. And what you can see here is that if you apply the Chicago criteria from clinical trials, or the team criteria, or the consensus yellow criteria, over 90% of patients had at least 1 hour between 8 to 5 p.m. that they were safe to mobilize. And if you look at how many hours in that 72-hour period were they eligible to move, it's about 3/4 of the time. And so patients actually are meeting the eligibility criteria earlier than we think. Now, if you apply a more conservative approach to say, I only want everything to be green, the least risk for these patients, you're still about 85% plus patients are meeting those criteria, but you have less windows of opportunity to do so. So if you look at what is the average time with which a patient would meet eligibility from intubation to the different criteria. So if you apply the Chicago or the yellow guideline criteria, patients are meeting criteria within 12 hours. So they have sufficient stability to at least think about mobilization. If you apply the team criteria, there's a slight delay due to this additional stipulations of organ support. And if you apply the green criteria, there's a little further delay. But again, all within 24 hours of mechanical ventilation. So do these definitions matter? So if I look at the risk of meeting an eligibility criteria as compared to the Chicago definition, if I'm in the yellow criteria, it's pretty much performs the same, where most patients will be eligible if they're eligible for Chicago as well as eligible for yellow. However, if I apply the team criteria in blue, then my risk of meeting eligibility drops by about 28%, again because of the guardrails of the maximum PEEP levels and maximum vasoactive doses. And if I'm even more conservative and apply only the green criteria, my opportunities to mobilize decrease by about 44%. So these sort of standards matter. If we're going to choose eligibility criteria for getting out of bed, I would argue that it should probably be in line with what the guidelines have said, and it should be informed by, am I being so conservative that I'm actually not letting patients be eligible at the time that I know this intervention is effective. And so I would argue that perhaps our perceived ineligibility for hemodynamic instability actually is not borne out in objective reality. These criteria are discrete elements in the electronic healthcare record, so it really could allow for us to do a real-time screening tool instead of having to do a handmade checklist. This could be one way to automate this screening approach and also ensure that we're applying these definitions in a standard way. So let's talk about another common barrier, which is consciousness. What I'll say is that after walking through the ICUs here, it doesn't seem like a rampant problem of having patients awake. But I will say at our institution, it's not as common. And that's because we don't necessarily standardize or have an objective way to always do an SAT screen. The one aspect of the SAT screen that always gets sort of manipulated potentially is the agitation part. Any signs of life could be interpreted as agitation, and often when that box gets checked, the patient becomes deemed ineligible for awakening. But if you look at the SAT screen criteria as published in the clinical trials, they're very specific that you can be awakened unless you have active seizures and alcohol withdrawal, unless you've received more sedative in the last 30 minutes, so not the whole day. If you're on neuromuscular blockade, if you have acute myocardial ischemia or increased intracranial pressure. And so if you think of the average ICU patient, they don't actually meet these criteria every day. They actually are able or eligible to be awakened sooner than you think. And in fact, in the clinical trial, over 90% of the patients met criteria to be awakened. And they met that criteria within a little over a day of being intubated. So we should be waking up our patients as early as day 2, potentially based on these data. And so our question was, at least in the United States, are SATs happening? So using the same consortium of now down to 13 hospitals, we looked at about 60,000 ventilator days. And what was interesting is that we found that SATs are interpreted in different ways. A true SAT is that you hold the analgesia medicine and you hold the sedative. You allow the patient to awaken. And if the patient demonstrates agitation, you start those infusions at 50% of the dose. What we found was that SATs sometimes could be partial, where only the sedative was held but the analgesia was continued, and that when they were resumed, that these doses were not at 50% of the prior dose. So we had to make some new definitions here. So if we take the true SAT, meaning complete interruption of sedative and analgesia, you'll see these light blue bars here, and the compliance is around 40 to 50% of the ventilator days. More common was the partial SAT, where only the sedative was held but analgesia was continued. And what was surprising is that if you rely on SAT definition to be based on documentation, so that's the brown lines here, which is the bedside staff will document, I did an SAT or I did not. That in some institutions, they would document an SAT was done, but it was not done. So this can be sort of a little bit of misdirection, where we think we're awakening patients, but we're actually not doing it because the infusions are not being documented as held, or that all of them are not held at once, or when they're resumed, they're not resumed at 50% of the dose. And this can really delay mobilization due to the consciousness not being sufficient. But, I can hold a sedative, but it's hard to know, are they awake? Because you want these patients to be awake to engage in the most they can for a mobilization. So if I define an awakening just on stopping the sedative alone, then maybe I'm 50% compliant. But if I'm trying to stop both, maybe I'm 30% compliant. But if I actually make the definition a true awakening, meaning it's fidelity, it's not just holding the sedative, but letting patients awaken, then the compliance drops even further. So only 16% of the days do you see that the sedatives are held and the level of depth of sedation actually goes to 0 and above. So these are the lies, at least in the United States, that we tell ourselves, that we're awakening and that we're letting patients actually be awake. And so it's important to follow and make sure that these high-quality care practices are actually being done as intended. So some lessons from looking at the electronic healthcare data from at least the United States is that maybe the perceived barriers we've seen in terms of hemodynamic stability or awakening are not borne out in objective reality, and that perhaps we should be following these in terms of not do we uptake these interventions, but are we actually doing them as intended? Not did we do it, but did we do it correctly? And that could be making sure if we do mobilization, if we really want to see the benefits, it has to be early. And so in some ways, we have to set a timer in our mind that's set at the moment that they're intubated, trying to get that first session within the first 72 hours. Similarly, if we're holding the sedative, it's not just about holding it, but it's actually waiting for the patient to awaken so that they can engage in the highest level activity possible during a session. And so how could we potentially do that? Well, all of these analyses were done using discrete data elements in the electronic health record. You could imagine we could streamline a lot of this eligibility screening within our health record to identify patients who are ready to be mobilized, ready to be awakened. And that may be a way to coordinate teams and streamline this high resource intensive intervention. So what would that look like? So we just built this tool at the University of Chicago where it runs in real time and it takes all the patient's vital signs and dictates whether they're in the red category or some yellow or some green. And every time a vital sign gets updated, the stoplight gets updated too. We also added in some rule-based identification for SAT eligibility so that this patient here, if they're green for SAT, that means they're on a ventilator and they have no exclusions to be awakened. And yellow means that maybe one of their parameters might be a little bit out of range, but perhaps we should go ahead and assess for mobilization. Versus a patient in red is probably someone shouldn't get mobilized because they've met one of the red criteria. However, they still meet criteria to be awakened. And in black here, this patient's not on a ventilator and they're green, so you should go ahead and go into that room. And then we're trying to also track this in real time in terms of a compliance dashboard, where every patient has a clock to say, I was admitted 3 days ago, I've never been on a ventilator, and so I should be seen as soon as possible. Or I was intubated yesterday, and now I have 25 hours left for me to get my first session in. And this is a way for us to, in real time, really capture the patients that were vulnerable for not getting the correct timing of mobilization. So mobility is a complex intervention, and I just said that we're trying to shove in a complex intervention in the first 3 days where patients are trying to survive. And so I understand that that can be quite challenging to have an intercalation of the resuscitation with rehabilitation. But, mobility is a team sport, and I think it's a testament to how cohesive and how well an ICU team works together. It requires a physician to order therapy and also select a sedation strategy that is conducive to that. It requires the ICU to be organized and have protocols that not only dictate the safety for awakening, but also the safety for mobility and have the adequate staffing to do so. It requires nursing staff to awaken patients and a therapy team and potentially a respiratory team to agree and apply these criteria in a standardized way so that no patients get missed. And this is all, again, during a very heavy workload time. So it really relies on a mobility culture, some team cohesion, a lot of experience and comfort with this. And this is all mainly because we want to have adequate stability for the patient and adequate consciousness in order to deliver the mobility at its highest level as intended. And so how could we implement that? It doesn't require fancy tools with the electronic health record. It could be something as simple as when we're thinking about sedation, maybe we have a sedation stewardship program. I, as a clinician, can't order the most industrial type of antibiotic for every infection. That's because the pharmacist, guards against that. So maybe we don't get access to all types of sedative without trying a non-sedative approach. Maybe our order entry guides us to the right guideline-based sedation therapies. Perhaps we can apply EHR tools that real-time screen patients for SATs and awakening. But I would like to know on a given day how compliant I am with the patients I'm in charge of. How many of those patients got awakened when they should have? In addition, everyone needs to get trained how to work together and how to ensure that these other goals for high quality care are met while we're resuscitating the patient. And perhaps we can sort of decide what are the eligibility criteria to get out of bed and ensure that those criteria are met within the first 72 hours. And then finally, maybe there's a indication to start finding the patient who is at risk of losing their function and should be seen and prioritized. That's one area of unknown. There's so much heterogeneity in the critically ill population. I'm sure that there might be some individualized treatment effect that we have yet to find. And perhaps for this resource-intensive intervention, those who would benefit from the earliest intervention may be identified that way. So with that, I'll conclude with saying, timely implementation of ICU rehab will really require some real-time screening of eligibility for mobility, making sure that it's complemented with implementation practices for sedation, and requires a coordination and cohesion of multidisciplinary staff. In addition, we have to pay attention to our timing and root it to the timing of intubation, and perhaps some EHR-based tools can help streamline that process. So thank you so much.